Good afternoon, everyone. Welcome to our HNF webinar series. We're very happy to have our eminent speaker, Dr. Chung Seng, today to speak on the principles of geriatric palliative care. But before we do that, I'd like to invite the CEO of Home Nursing Foundation, Dr. Christina Chung, to give us a very short opening address. Christina, please.
Hello, everyone. It's my great honor to welcome all of you to Home Nursing Foundation's inaugural CME session. And of course, we are very thankful for Dr. Lee for spending his precious afternoon to share with us the latest and approach in palliative home care for frail elders. As you know, Home Nursing Foundation has been providing home care for the sick and needy for more than 45 years. And we are the largest home care charity in Singapore. And over the years, we've seen many of our patients becoming frail and also having a different level of needs that we really want to be able to care for them and provide the utmost comfort and a good approach to supporting their families. So with this series of CME, it's very aligned also with the national direction to provide the opportunity for many of our elders who are frail and nearing the end of life to have the option of passing away at home comfortably, supported by loved ones in the warmth and comfort of their homes. So this is the start of a series of CME that we hope you will find helpful as well. And please feel free to also share this with your friends and colleagues who are interested. And many of the family physicians who have built very long-term relationship with your patients will also find this helpful, as some of our patients, have this desire to also pass on at home or nearing the end of life and face many medical issues that you want to be able to treat in the most comfortable and respectful manner. So this is the first of a series. I'm very excited and looking forward, and please feel free to ask questions, and it's a very warm and collegial environment that everyone should feel free to share your own experience later on at the end of Dr. Lee's sharing. So thank you very much, Dr. Lee. Wai Chung, you will be introducing.
Yes, I'll introduce Chung Seng.
Thanks, everyone.
Thanks, Christina. Yes, before I introduce Chung Seng, it was impolite of me also not to introduce myself. My name is Dr. Wai Chung. So I'm an old friend and a colleague and also a classmate of Dr. Chung Seng. So I'm the medical advisor of Home Nursing Foundation. I'm very happy to be able to be here moderating this session. So we're going to have a very rich sharing by Dr. Lee for about 45 to 50 minutes. After that, perhaps we have got some 10 minutes to 15 minutes time to have some Q&A. We like to keep it 1 hour so that it's easier for you to plan your time. But so I'd just like to introduce Chung Seng. Chung Seng started as a GP. We were in a GP clinic in Taman Jurong before. And then after that, he joined Bright Vision Hospital. He was there as a pioneer batch with Dr. Li Liang Ti, Li King, Kok King, and learning under Dr. Yi Chai Hua. And then he became a geriatrician, going through the the further training and examinations. And finally, he's now a consultant palliative care physician. So if anyone understands community medicine, community geriatric care, primary care, Dr. Lee is the person. And now he is running the palliative care ward in St. Andrew Hospitals. He's also a palliative care consultant staff of Tan Tock Seng Hospital. So with that, I think Dr. Lee is really the right person to share with us on the application of palliative medicine in the geriatric population. So Chung Seng, please.
Thank you, Wai Chung, for the kind sharing. Yeah. Okay, let me share my slides first. Can everybody see my slides now?
Yes, we can.
Yep, can. Okay, good afternoon, everyone. Thanks for taking time to attend this talk, despite your busy schedule. Today, I'm Chung Seng from Tan Tock Seng Palliative Department. Yeah, I wasn't trained as a geriatric specialist, but I'm trained in the palliative medicine. Yeah. So anyway, I think this topic itself is very important, especially the recent announcement by the Health Minister Ong about trying to support end-of-life care in the community and letting the patients passing on at home. Yeah. So without further ado, my today's topic on the principle of geriatric palliative care, I'll be touching on how do we identify patients who are coming to the end of life. What are some of the prognostic tools that we use, and why is it important to, in terms of after identifying this group of people, why is it important that we do communicate with the patients and their loved ones, especially on ACP discussion? And what are the common symptoms that we do face in end-of-life care, and how do we manage them? We actually selected things like, for example, pain, shortness of breath, delirium, as well as seizures, because they are quite common in this group of people. Yeah. So the first thing is about identifying patients whom we are approaching end of life. This is a workflow that is being adapted from the gold standard framework. So if you look at it, is the first thing that we look at is the general indicators of decline, whereby you see patients having a decreased activities, whereby the functional performance status actually has declined to the point whereby there's limited self-care. They tend to be like chair to bed bound most of the time. And there's also have this group of patients also have multiple comorbidities, and having these advanced diseases whereby they tend to be very unstable and has been deteriorating with a complex symptoms burden. And they started to show that there's a reduced response to treatment or limited reversibility. And eventually it comes to a point whereby there's limited benefits from further active treatment. What I find that is also quite a good indicator is things of weight loss, whereby they have quite a drastic weight loss of usually more than 10% over the period of like short months. And they tend to have repeated admissions to the hospital. And if they do some blood tests, usually the albumin tends to be less than 25. Yeah. So these are the group of patients that are having some general indicators of decline. Then we look at what are the specific clinical indicators that is causing this decline in them. So it's divided into two big groups. One of them is advanced cancer, which is a predictable decline, or we are looking at organ failures. Yeah. So for advanced cancers, I think all of us know is that if they have a very poor functional status, whereby they are spending most of the time in bed, usually the prognosis is about 3 to 6 months. Yeah. For patients who have end organ failures, unfortunately, their decline tends to be very erratic, which means that they go ups and down. And what are the common types? They're commonly so-called scenarios that we do see are things like, for example, those people who have advanced COPDs, heart failures, advanced heart failures. There's also have renal failures, and advanced neurological disease, things like that. Patients who have advanced Parkinson's, dementia, motor neuron disease, as well as massive strokes, as well as advanced dementia, as well as frailty. Yeah. So I will slowly sort of like go through some of them. Like for example, patients with advanced chronic obstructive pulmonary disease, COPDs, right? This will be covered by in one of the topics by my colleague. Usually, these are the criteria whereby they have FEV is less than 30%, and they are on a long-term oxygen therapy. The MRC dyspnea score scale is either 4 to 5. 4 is whereby the patients are breathless after walking about 90 meters. 5, you are talking about the patients is so breathless until they can't even leave their house. And any slight activities like things like, for example, dressing, undressing will cause them to be breathless. They do have problems with cor pulmonale, with right heart failure as well, and they tend to have recurrent admissions to the hospital. Usually is defined by more than 3 times in the past 1 year. For advanced heart failure, which also will be covered by my colleague in one of the seminars, is defined as at least 2 of the following, whereby they have a New York Heart Association, either 3 to 4 or 4, having recurrent admissions to the hospital because of a fluid overload or intractable chest pain. And the other things is, of course, this is despite optimal therapy, but having poor symptoms control. For advanced renal failure, is defined as a stage 5 CKD, whose condition is deteriorating. And the patients actually decided not for dialysis, or they because of the underlying other medical conditions, they could not continue the dialysis anymore. So these are the group of patients whereby the prognosis tends to be short if they have been on long-term dialysis and then they couldn't continue with it. For those group of patients who decided all along to be having conservative treatment whereby there's no dialysis, usually at the late stage whereby we start to see the patients, they tend to be having symptoms. What the symptoms are? Things like nausea, vomiting, anorexia, pruritus. They start to have a functional decline and intractable fluid overloads. Yeah. For advanced neurological disease, the things that are commonly encountered are things like advanced Parkinson's, motor neuron disease, or cases of massive strokes, right? Usually you will see that there's a progressive decline in the physical as well as cognitive function despite optimal treatment. There's also swallowing problems leading to recurrent aspiration pneumonias, and their speech will be getting more and more difficult to the point where they have difficulty communicating. Yeah. Advanced dementia is another group that we see. We actually use the fast staging, and how do we select patients to be under who are so-called approaching end of life? Patients who are going into fast stage C and above. And they tend to have recurrent infections and starting to develop pressure sores because most of them will be bed bound. Yeah. For frailty, these are the groups whereby overall we actually use the clinical frailty scores of more than 6. And overall, they tend to be having generalized weakness and fatigue. For clinical frailty score of more than 7, right? Of 7 means that they are severely frail, and most of the time they are completely dependent in all the ADLs. Yeah. So I will going through the prognostication with you all. I will just cover 2 of them with the interest of time. The fast staging is being used for dementia, and the clinical frailty scale for frailty. So for the fast staging itself, is divided into 7 stages, and the 7th stage itself is subdivided into A, B, C, D, E, F. Okay, so for the stage 1, you are talking about those that are so-called no forgetfulness, yeah, and then subsequently there's a subjective forgetfulness. Then they start to lose a bit of IADL. IDL is the instrumental ADLs, whereby they started the higher functioning started to drop, and then the IADL started to have difficulties, and eventually the daily activities of living will require supervision and subsequently dependent. Yeah. So when it comes to this stage, it's a fast 7, right? It's subdivided into this A, B, C, D, E, F, whereby initially they started to have problems with the loss of speech, yeah, and subsequently the loss of mobility, unable to sit. Then subsequently is more of a bed bound state, whereby they started to have difficulty, can't even smile or holding up their head. So when they have more than for fast 7C and greater, the mean survival time is unfortunately is only 3.2 months. Yeah. For clinical frailty scale, right? They are for fast the clinical frailty scale 7. We are referring to patients who are completely dependent for their personal care. Usually they have they are chair bound. at least. And then what happens is that there is caregiver that have to attend to their basic needs. For 8, we are talking about patients who are very severely frail and they are completely dependent. Yeah, and usually these are the group of patients whereby any slight minor illness, it seems like just a viral illness or even a COVID per se. Yeah, recently, these will be the ones that is being tipped. It will tip them over, and they just go into the so-called the declining stage to the point of death. Yeah. So there's 3 main trajectories of a decline in end of life. So you have patients who are having the cancer group, right? You'll find that their function is quite high, even they are having advanced cancers, but they will have a sharp decline in the function in their final weeks to short months, of the disease. As compared to organ failures, you will see that they are already functioning at a lower level, like patients with COPD, heart failures, or renal failures. You will see that they are actually at so-called the function is actually lower, and then there's dips in the function as when there is exacerbation in the condition, which means that they are admitted because of infective exacerbation of the COPD, but they do recover. But their recovery, unfortunately, of the function, unfortunately, is not back to their baseline. They tend to be dips a bit lower. So with each insult itself, the function drops to the point of death per se. This is as compared to those patients who are having advanced dementia or frailty, whereby their function is already low to begin with, and with each so-called insult itself, it just drop a little bit, and then subsequently they just progress to the point of death. Yep. So knowing all this, it's very important to actually have open communications with the patients and the loved ones before the patients really lose their capacity, in decision making. So ACP is something that we do advocate very strongly. We do identify patients who are coming to the end of life. It's actually a voluntary process whereby the patients discuss, state, or document their values and wishes with regards to the future care with their loved ones. In events whereby if they are incapacitated, at least the loved ones knows what they want. So the healthcare providers are the one that helps to facilitate this discussion with them. Yeah. So why is it important? All of us, will definitely experience death, but most of us do experience a very chronic one, unless it's a very sudden one like a heart attack. Yeah, but most of us actually experience a very chronic, progressive, tough illness, and ultimately, it will be the fatal event. Yeah. So when it comes to the point whereby end of life decisions has been made, almost 50%, unfortunately, are incapable of making that decisions. Yeah, because they could be having delirium or because they couldn't communicate even subsequently. Yeah. So healthcare professionals, when facing this uncertainty in the decisions making, so the default will be to treat. And the healthcare providers, the caregivers, their loved ones, because they have not spoken to the patients about the end of life care issues itself, they can't really predict what the patients want. And what they would choose? They would choose so-called treatment. Yeah. And or the decision making sometimes can be quite stressful or burdensome if they decided not to. Yeah. So in order to provide these future conflicts and confusion, healthcare, the caregivers can actually have less burden or less stressful when they actually knows the patient's wish, and this actually helps to promote quality end of life care and dying with dignity. Okay. So now I will come to the symptoms symptoms that we do face in our end of life care. The first one that I will be covering will be pain per se. I will be covering on what is the definition of pain, how do we classify pain, and how do we manage them. Yeah. Pain, and as everyone knows, is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Yeah. So, as we all know, is that pain is divided into big groups. There's a nociceptive, there's a neuropathic pain, and for nociceptive pain is subdivided into visceral and somatic, and somatic can be subdivided into deep or superficial. So for nociceptive pain, usually is due to a stimulation of the nerve endings of the skin or deep tissues, which is sensitive to noxious stimuli. Yeah, and for nociceptive pain, that is due to the somatic causes. Yeah, is usually due to subcutaneous, or if it's deep, it will be musculoskeletal. The patients were able to describe that it's a very sharp pain, it's very localized, and there's localized tenderness as well. So examples of it is things like arthritis, fractures, and bone metastasis. The other group of nociceptive pain, you are talking about visceral pain, is due to infiltrations, compressions, or extension, stretching of the thoracic and abdominal visceral. And usually the patients will describe it to be very poorly localized, deep squeezing, pressure type of sensation. And with the acute, they tend to be associated with nausea, vomiting, or diaphoresis. And some of the good examples would be like liver metastasis, pancreatic cancer, or things like intestinal obstructions. That could would be a form of visceral pain. Yeah, in advanced cancers. Yeah. So some of the visceral pains can have referred pain. I think this is something that we learn in medical school. Yeah. So the visceral pain can actually refer to some sites that is remote to the site of lesions. Like for example, shoulder pain when the diaphragm is irritated. For neuropathic pain, is usually caused by a lesion or a disease of the somatosensory nervous system, and what the usual cause is tumor compressions or infiltration to the peripheral nerves, the nerve roots, spinal cord, and it could also be a result of a treatment. For example, for metastatic or radiation brachial plexopathy, yeah. A good example would be with patients with breast cancer, whereby there's a lot of axillary lymph nodes. The axillary lymph nodes actually pressing on the brachial nerves itself. They do have this pain per se that is in the so-called distribution of a brachial plexus. Spinal cord or caudal equina compressions are due to the spread of the cancers. There is to the spinal bones itself, vertebrae itself, and it can actually goes back, goes into the spinal cord and causing the compression. Yeah. Post-hepatic neuralgia, or it could be due to treatment, as just now we mentioned. Yeah. Things like cisplatin neuropathy. So the patients tend to describe this type of pain as pins and needles, electric shock, burning sensation. Sometimes they do have a cold sensation as well. And it's tingling, pricking, and then shooting. Yeah, and the radiation, if you ask about it, is that it's usually to the areas that is distributed. Area of distribution is corresponding to the dermatomes as well as all the peripheral nerve distributions. Then they do have some other type of description to it, things like allodynia or hyperalgesia. For allodynia, is defined as a pain that is elicited by non-painful stimuli, which means that things like a gentle touch to the skin itself can cause pain per se. Yeah. Hyperalgesia, you are talking about a hyper response to a painful stimuli. Yeah. So all of us knows how to assess pain in a patient that is able to communicate with us. You always ask, okay, what is the we use Socrates, whereby you are talking about the sites of the pain, the character of the pain, whether it's any exacerbating, relieving factors, yeah, and having a pain score to it, kind of thing, yeah, and how does it affect? How does the pain affect the sleep? How does it affect the function? How does it affect the social? So we know how to communicate. Get a pain history from our patients who is able to communicate. But how about assessing pain in the patients who are uncommunicative? So we actually use we actually look at the vocal expressions, things like, for example, with the patient, is the patient moaning and groaning, grunting, facial expressions whereby they actually grimaces, or their posture whereby they're having a protective posture, right? Whereby they actually clutching or holding on to the side rails, or when you move the affected area, they actually reach out to their affected area. Some of the patients do present with restlessness as well, and yeah, are they rubbing or massaging the affected areas? Yeah. For patients who are still functional, right? You might want to, if the patient is still moving, you have to look at the gait, any change in the social interactions, or their appetite or sleep pattern. What I find is quite good is that we always try to get a collaborative history from the carers. Usually it's either the helper or the person that is looking after the patient. They will be able to tell you that this is not normal. Yeah. So after knowing all this, then the approach to the pain control is that we use the WHO analgesia level. Yeah. So step one, which is non-opioids analgesia, we are talking about the approach to mild pain. And for weak opioids, we are talking about things like tramadol, codeine. Then for mild to moderate pain. For moderate to severe pain, we are talking about potent opioids, things like morphine, fentanyl, or oxynorm, or pethidine. Yeah. And of course, the fourth step, we are talking about invasive therapy for intractable pain. Invasive therapy, we are talking about nerve blocks or intraspinal type of blocks per se. Things like epidural, sorry, not epidural, but intrathecal nerve blocks. So WHO recommendations when we offer using opioids is that if possible, always go by the oral route, by mouth. Yeah, try not to go by injections or especially IM because it's painful. And then round the clock, which means that we have to give the analgesia around the clock because the half-life of the medicines will wear off and the pain will come back, especially if the patient has chronic pain. Yeah. Excuse me. And of course, sometimes you do have to prescribe it prophylactically, especially if we know a particular activities actually trigger the pain per se, so or breathlessness. So we actually preemptively give the medicines before the activities, and always prescribe a breakthrough dose, which means a rescue dose, which means that if the regular dose does not control the pain or pain, at least the patients are able to take the breakthrough. By the ladder, as you mentioned, the WHO ladder, yeah, and by individual, which means that we need to titrate the medicines. A dose that works for one patient doesn't mean that it will work for the other patients for the same condition. So we have to titrate individually. So the types of analgesia just now we briefly mentioned, non-opioids, opioids, as well as the third group is called adjuvants. Non-opioids, there are things like paracetamol, NSAIDs, yeah, and COX-2 inhibitors. Opioids, there's weak opioids, there's codeine, tramadol. Strong opioids, there's morphine and pethidine. Adjuvants are good, our good friend, whereby we actually use it in combinations with our opioids to control the pain, especially neuropathic pain. What are the examples of adjuvants are listed here? There's steroids, corticosteroids, there's antidepressants. Usually we use things like amitrip or nortrip. nortriptyline. The anti-epileptics, things that we use is things like gabapentin or pregabalin. Antispasmodic is our good old buscopan, and muscle relaxants are things like biclofen. Yeah, bisphosphonates, we also use it for patients who have bony metastasis that is causing pain, but it's not the first line. Yeah. So the choice of analgesia, and what are the things that we could do consider? Yeah, is that if the patient is opioids naive, right? If we want to start morphine, usually we start with 2.5 up for up to 4 to 6 hourly. We have to talk about we have to start at a lower dose, especially 2.5, 8 hourly or even lower. If the patient has both if the patient has either renal or hepatic impairment. For renal impairment, we are talking about a creatinine clearance of less than 30. Hepatic impairment, we are talking about people who has advanced liver cirrhosis or having a lot of liver mets causing a raised bill, yeah, kind of thing, yeah. Patients who are very, very elderly, yeah, we have to be very careful. Usually, we will tend to in the Geri populations, right? We will tend to have to start with a lower dose. I mean, with this dose, but at a spread out the frequency. And the other one is, of course, patients who have a risk of respiratory depressions, like patients who have a type 2 respiratory failure in the COPDs or neuromuscular diseases. Yeah. And always, after we start the patients on a regular dose, it's very important to prescribe breakthroughs. And the breakthroughs tends to be 1/6 to 1/10 of the daily dose. Yeah. And the other things is, we have to consider adjuvants, as now I was mentioning, for neuropathic pain. And also talk about, we also have to consider COX-2 inhibitors as well, no opioids. Yeah. So the next thing is COX-2 inhibitors or NSAIDs. Why is it important? Because it has this antipyretic, anti-inflammatory, and analgesia effect. And it's useful in patients who have pain secondary to bony metastasis. Yeah. Or they have a pain that is related to an inflammatory type of etiology, things like pruritic chest pain, musculoskeletal pain, rheumatoid arthritis, osteoarthritis. It tends to respond fairly well with NSAIDs as well. Yeah. So some of the NSAIDs that we do use things like for ibuprofen, naproxen, and diclofenac. COX-2 inhibitors are our good coxia, all this stuff. Yeah. Fentanyl patch is another big group that we tend to use. There's 3 formulations. Yeah, there's injectables. There's a transdermal that all of us are familiar with. The transdermal, transmucosal, sorry, it's not easily available. It's the Abstral. Yeah. So transdermal fentanyl patch, usually the onset after we put it on is at least 8 to 12 hours before it starts to act. And each patch actually lasts for about 72 hours. And the peak serum concentration after initial applications is about 20 to 72 hours. After removal, there's still medications in the body. So there's actually a gradual decline in the fentanyl concentration. About 50% in 24 to 72 hours, yeah, for 27 hours. So usually, what happens is that if we take off the fentanyl patch and we want to start the patients on the additional opioids, right? We have to take into account what is that there are still fentanyl, so there's still in the patient's body, yeah. Okay. So what to consider is that knowing that this time of onset is 8 to 12 hours, please do not use it when the patient is symptomatic, because it needs titration, because it will take a while before before you see the effect. And only consider using it when the symptom is well controlled on a regime of immediate release opioids. This means where the pain is well controlled with a fixed dose of opioids, you want to convert to a fentanyl patch. Yes, that's where we will convert. The applications itself, where to put it, is actually over those intact areas, things like the chest, back, and the upper arm. Please do not cut the patch into half or expose it to heat, because they can actually cause the retinal absorption to be increased. When we see this group of patients, please always check for existing patches, because it might be hiding on the patients. And if we put another patch, it will be a double dose. Yeah. And of course, the other thing is, of course, when is the due date. This is very important, because some of the patients are thought that this fentanyl patch is a koyo, so they actually put a 1 or 2 patch. I had one patient that did that. Yeah, so we have to be very careful. So after putting on the fentanyl patch, how do you prescribe the breakthroughs then? So the breakthroughs of subcutaneous fentanyl is 1/10 of the total daily dose. Yeah. So imagine if this patient is on a fentanyl patch of 25 mics per hour, the total daily dose of the fentanyl patch of fentanyl, sorry, is 600 mics a day. And so the breakthroughs of the subcu fentanyl will be 600 divided by 10, which is 60. So it can be given up to 1 hourly to 2 hourly. Okay. So from how do you give oral morphine if this patient is on a so-called fentanyl patch? Yeah. So you have to know. So the breakthrough morphine is usually 1/6 to 1/10 of total daily dose of the morphine. So if a patient is on 60 milligrams of morphine a day, yeah, you divide by 6, this give you a 10 milligrams up to every 4 hourly, which means you can serve the breakthrough up to every 4 hourly. So for instance, this patient is on a fentanyl patch of 25 mics per hour. In total, just now we come out, right, is total fentanyl was 600 a day. So in order to convert to morphine, right, you divide by a factor of 10. Yeah. Why 10 is because this is in terms of mics. Morphine is in terms of milligrams. Fentanyl is 100 times more potent than morphine. So so that's the reason why you divide by 10. Yeah. Okay. And so you come down to a factor with a figure of 60 per day, and the breakthrough will be 1/6 of this dose. So it's 10 milligrams. So this is a way to go back, which means that if this patient is on a morphine and you want to switch to a fentanyl patch, you divide by 2.4 lah. Yeah. So this is how you go back to 25 mics patch. Yeah. So what happens if the patient deteriorates and unable to swallow meds? Yeah. So what we do is that we actually convert the medications into a parenteral route, which means it's a subcu infusion. So what are the causes? What are the instances whereby we convert? Things like, for example, if the patient is unable to swallow because they are too ill, too drowsy, or there is a problem with absorption. Like, for example, a patient with having intestinal obstructions, or patients who is having severe nausea, vomiting. So what to take note is very important is that when we want to convert oral to parenteral, we have to divide by a factor of 3, which means that if a patient is on a morphine of 30 milligrams a day, the parenteral is only 10 milligrams per day. And you divide by 24, it will come up to 0.4 per hour. That's how you run the morphine infusion. If you are not familiar, please consult a senior doctor who are familiar with the opioid use. Yeah. Okay, so this is pain. The next topic that I will be talking about is breathlessness. So what is breathlessness? Breathlessness, I'm covering on what is breathlessness, what is the verbal, non-verbal cue, and how is the management. Yeah. So what is breathlessness? The patient will describe to you that there's difficulty in air movements, there's an increase in the effort, or there's a generalized distress that I'm suffocating, kind of thing. Yeah. So unfortunately, breathlessness is a very subjective type of sensation. Yeah. And it actually, the experience actually derives from multiple interactions. It's not so straightforward that breathlessness is just shortness of breath. There's this physical component, there's a psychological component, social component, spiritual component. And of course, if the patient is able to communicate with you, they will tell you that I'm breathless, and then of course you will start the treatment. But what happens is that if the patient is unable to communicate, so you have to look at the non-verbal cues. This is a respiratory distress observation scale that we also will use to guide our treatment. Things like, for example, the heart rate, respiratory rate, whether is the patient restless, is there any paradoxical breathing pattern, any use of accessory muscles, any grunting at the end of expirations, and nasal flaring, looking fearful. Yep. So anything that is between less than two or less, there's a little or no respiratory distress usually. But it's more than 3, they tend to signify there's at least moderate breathlessness. Okay. So for the general measures of treatment, you are talking about oxygen if the patient is hypoxic. If the patient is not hypoxic, we tend to give the patient a standing fan to blow, so that this actually, with the movements of the around the nostril area, actually helps with this to relieve the sensation of breathlessness. Of course, the patients will be trained how to have this anxiety-reduced training, which means that they will learn how to take regulate the breath, and then pursed breathing, that kind of thing. Yeah. So these are the things that we do train the patients how to, in response of SOB. Other things, of course, if the patient is having chronic obstructive lung disease, if the patient is beneficial to do pulmonary rehab, this group of patients will go for the pulmonary rehab. Of course, in the acute hospital, we also will be discussing about non-invasive ventilation for patients. How about pharmacological treatment? Pharmacological treatment itself is divided, treating the symptoms and of course treating the underlying cause. Always remember that. Yeah. So in terms of treating the symptoms per se, yeah, we look at starting opioids, things like morphine, yeah, which is very good. Usually we will have a gradual titration of the medicine. If the patient cannot swallow because of increase of the breathlessness, then we use Tranquil. The other groups that we do use is the benzodiazepines, things like midazolam or alprazolam. They are good adjuvants to opioids, help to relieve the anxiety. And of course, the third group is antidepressants. Things like mirtazapine does help as well. So for breathlessness, just now I was mentioning, morphine, the starting dose can be 2.5, 4 to 6 hourly, and if it's not enough, then we push up to 5 milligrams. Yeah. Parenteral doses that we want to start is things like sub-Q morphine, about 0.2, and then we slowly titrate up 0.2 milligrams per hour. Yeah. Other adjuvants that we did mention is things like alprazolam, 0.125 to 0.5, PRN up to 3 times a day, and at night you tend to use lorazepam because it's longer lasting, for about 0.5 to 1 milligrams for the insomnia. The third topic that we'll be discussing is delirium. How do we recognize delirium? How do we do a formal assessment? What are the types of the delirium? What is its etiology and the management? Yeah. So everyone knows about the DMS-4 so-called definitions of delirium. So this is for your info. In short, we are talking about disturbance in the consciousness, whereby there is a reduced ability to focus and having attention. And there's a change in the cognitions or perceptual changes as well. This condition is have an onset at a short period of time, and they fluctuates during the course of the day. And there's also a history of examinations and investigation that's so-called pointing to an organic cause. There could be psychomotor behavioral disturbances as well, and emotional disturbances. Yeah. So this is a confusion assessment methods. Is something that we use at bedside to actually assess whether this patient has indeed delirium. So it's very easy to use. It's 1, 2 has to be present, or so 1 and 2 has to be present, and then plus 3 or 4. Okay. So 1 is acute onset of the condition. That's with a fluctuating cause, and there's inattention as well. Plus, either where they have disorganized thinking or a altered level of consciousness. Okay. So types of delirium is hypoactive, hyperactive, and then there's a mix as well. So for hyperactive, tends to be more prominent. You have which is also less picked up, whereby the patients will be hypoarousable, very lethargic, sedated. Yeah. So this is fairly common in the palliative setting. Hyperactive, they are hyper alert, very restless, agitated. These are the ones that the caregiver will highlight to you, and you will need to start some treatment because it's very disturbing. And of course, there's a mix whereby they can be fluctuating between hypoactive and hyperactive. Yeah. So always look at what is the etiology of delirium. This is just a acronym of what are the possible causes, things like drugs, whether they have a visual and hearing impairment that is causing it, low oxygen, low hemoglobin. There's a very common one is drugs, infection, having incontinence, restraints, all these things. Yeah, and metabolic causes. All these are very a common cause. Yeah. So this is a big table that's able to can help you see that wow, there's so much causes in that can lead to delirium. Yeah. So what is the approach to delirium then? There's a non-pharm methods, there's a pharm methods. Let's cover the non-pharm, yeah? So being in the community setting, it's very important that you have to make sure that the patient's environment is correct, whereby there's familiar faces, there's a soft lighting, involving the family in the care. And in the acute hospital, what we do is that we limit the movements of patients from one room to another. And there's as well as the staff that is looking after, if possible, having the same staff to look after the patient as well. And try to reduce the use of indwelling catheters, IV venous lines, if possible, especially restraints. Yeah. And in the daytime, if the patient is able to mobilize, please mobilize them. Adequate pain control, make sure that they pass urine and bowel. Yeah. And review medications that can cause the delirium. Yeah. And of course, if the patient is not too delirious in the daytime, you can do things like orientation as well. Yeah. And during the night itself, please allow them to have a continuous sleep. So it's to reduce the monitoring of this group of patients. Yeah. And in the daytime, try to involve them with activities so that they are not sleeping in the day. Okay, so these are the non-pharm methods that was described. And the pharmacological methods, the most common drugs that we usually use is antipsychotics, things like haloperidol, our good friend. The starting dose is oral, either 0.5 to 1 up to every 6 hourly. Yeah, okay. And if you will need to start a subcutaneous infusion itself, the starting dose is 5 milligrams per day if the patient is very agitated. Things that we can add on is things like our good midazolam. The starting dose of midazolam can be 5 milligrams per day on top of the 5 milligrams of halo, and then we titrate accordingly. If the patient is still able to take orally, we can use halo and just lorazepam. Yeah. A note something to take note is that benzodiazepines try not to use it as a first line for delirium because there could be paradoxical agitations. So just now I was mentioning to you the good old drugs is things like haloperidol and olanzapine are our favorite, especially olanzapine. They can be used in the home care because it can be served sublingually. Yeah, so it's a good dose is 2.5 PRN up to every 6 to 8 hourly. Yeah. Okay. Ken, the last topic that I'll be covering is seizures. What is seizures? What is the cause, and what is the management? So seizures, you are talking about is a neurological emergencies, and status epilepticus is defined as a prolonged seizures with multiple seizures, which with incomplete returns to the baseline. So the common cause is things like metabolic in nature, things like hypoglycemia, hepatic or uremic encephalopathy, hypoxic encephalopathy, or it could be a primary brain pathology, things like previous strokes, or brain tumors, or primary brain tumors, or brain metastasis. Yeah, and usually an infection can actually trigger a stroke as well. If there's some underlying brain pathology. Of course, please also look at our medications. So the first treatment itself is, of course, you have to turn the patients to the left lateral to protect the airway, and then ensure the environment is safe. If there's an oxygen point, you will give the patient supplement oxygen. And then subsequently you assess what is the cause of seizures, what is the prognosis of the patient, and whether the reversibility of the underlying causes is it consistent with the goals of care. Yeah. So the in a home setting, usually we will stand by diazepam, sulfonylurea for the caregivers to administer if the patient has seizures. In a hospital setting, then we will go to the second line, things like midazolam, whereby we can give IV or sub-Q, 2.5 to 5 milligrams, and it can be repeated every 15 minutes until the seizure is controlled. And subsequently, we will then start the patient's sub-Q midazolam infusion. Yeah. Of course, if midazolam fails, the third line, the third line will be phenobarbital. Okay. The other thing is AEDs, anti-epileptic drugs itself. If the patient is imminently dying, there's no role for anti-epileptic drugs. Okay, but if the patient is not imminently dying and if it's consistent with the goals of care, yeah, and the prognosis is long, then you may consider starting AEDs if there's no contraindications and if the patient is AED naive. If the patient is already on an AED, then you have to consider increasing the dose because it could be subtherapeutic. Yeah. So common AEDs that we usually use is things like Capra. Yeah, because it's having less interactions with drugs. Other common drugs that we use is a phenytoin as well as valproate. Okay, can. So for complete service that is under Seng and Dover Park, yeah. So we have this program impact under Seng. This is a program that the doctors and the nurses goes into the patient's house to actually assess the patient's condition as well as the management of symptoms. And these are for patients who have end organ failures, which we have in the first few slides, we have covered that. Yeah, program Dignity are for patients with advanced dementia, whereby we care for the patients in their own home. Yeah, Project Care is a group of doctors and nurses and even the social workers, allied health, that going into the nursing homes to support the residents in terms of end of life care. Yeah. Dover Hospice is a palliative home hospice. They do run both the inpatients as well as the home hospice. So for the Dover home hospice, they actually goes to the patient's house to look after. Majority of the patients are advanced cancer patients, and they do also look at after patients who have end organ failures as well. But majority are still under the program impact, or Project Dignity. Yeah. But now they are really slowly taking over some of the patients. Yeah. So the take-home message is that we have to identify patients who are approaching end of life care and to discuss the future care with the families early, and also to look out for symptoms of end of life care and also manage them accordingly. Yeah. Okay, that's the end of my talk. Yeah. So now we may open up to questions.
Thank you, Chung, for the very informative, very rich talk with a very rich content. So in the Zoom room, I can see that there are many doctors, and also we have our nurses from our foundation here with us. So I'd like to open the floor to some questions. So I think there's a first question from Dr. Chan. Well, can give some idea when government subsidies or when government subsidy and subvention will be available for palliative, HNF care, hospice, home care, the time frame, diagnosis in the last 3 to 6 months, 12 months in end organ failure, prognosis in terms of month may not be so clear. Maybe Dr. Chung, would you like to unmute yourself and maybe ask a question to Dr. Lee?
Here you hear me? Yeah.
Yes, Dr. Chan.
Yes.
Yeah.
So with end organ failures, even with the various diagnoses, some of them may decline quite very fast. Those would be quite clear cut when we call people in. And the subsidies may well be available, but sometimes, like you say, we're trying to sometimes make that diagnosis early, that they need a lot more support, even with the end organ failure, and they might still go on for 1-2 years. So actually, when would the government subventions be relevant? If we try to call whether for the home nursing or even the hospice palliative home care, and also the outreach of the project Say. Okay, yeah. Or is it only those who land up in hospitals, the frequent flyers, Okay.
Maybe I'll just take this question quickly. I think it's
Yes.
an administrative funding question, right? Currently, home nursing and home medical are subsidized according to means test, but these are not for palliative care patients who need a higher level of resources and frequency of visit. For those, I think the program that supports them is the ones that Dr. Lee shared, the program Dignity or program Impact. So those are the ones that specifically look after end organ failures and dementia, advanced dementia. The rest, which are non-specific, like frailty, is something that actually AIC, together with Dr. Ng's advice and consultancy, is trying to put together across the community care sector, but it has not been finalized yet, and that is definitely an area of need that we are working on to close the gap now. Yeah. I think if Dr. Lee, you have any other things to add to share with the audience about what are the possible programs and resources available, or we can take that offline and address some of the clinical questions that have been posted in the chat group as well.
Okay. Yeah. Thanks, Christina, for taking the answer. And Christina has mentioned rightly. So thanks, Dr. Chan, for the question too. The second question is about severe dementia and severe frailty. Chung Seng, do you know whether can they be accepted as cause of death when you sign CCOD?
Okay. Thanks for the question from Dr. Wong. Unfortunately, you cannot sign up as advanced dementia or advanced frailty. You still have to put appropriate cause of death. Usually for this group of patients, the common cause of death is due to infection. So you will then have to put down there that the cause of immediate cause of death is due to an infection, and then the contributing factors that is below, or the second causes is like, for example, dementia. Yeah.
Okay, thanks, Chung Seng. There's a question from Hui Ling. Nice to see you here, Hui Ling. She asks about something very practical. How do you administer subcutaneous infusions? Perhaps say from a community or from a GP perspective, we may not have strange driver. Chung Seng, do you have any advice for us?
Unfortunately, the infusions, sub-Q infusions is run by, we have to do it by a device, things like a syringe driver type of thing. In the community itself, usually we will then have to stand by so-called subcutaneous injections and teach the caregivers how to do it. But if we think that this is you need to do it like like very constantly. I'm not sure whether they really coming to that stage. You want to get the collaboration from a hospice type setting to actually run it. Yeah.
Chung Seng, like to add on. If I were to put a butterfly needle subcutaneously and then teach a family to give maybe morphine subcutaneously 4-hourly and so on, do you think that will work and be effective in managing symptoms?
That could be a possibility. It's just that the dose will have a peak and then comes down, then peaks comes down. Might not be so ideal, but yeah. But if you really as compared to a so-called medications that can be continuous. The other way to go about it, I was just thinking, is that I'm not sure how useful it will be a fentanyl patch at the late stage, whereby which means that if we think that the patient has still a few more days to go, not short hours, then a fentanyl patch may actually help to reduce the number of breakthroughs. Yeah.
Okay, thanks, Chung Seng. So Dr. Chan asked a follow-on question about oral morphine. Is it available in the community? Yeah.
Oral morphine is a non-controlled drug. You can use it in the community. Yeah.
You're referring to Miss Morphine, right?
Oh, yes, yes.
Yeah.
Miss Morphine. Oral morphine, we are talking about Miss Morphine. Yeah.
Yes, Miss Morphine, but
yeah.
It's not readily available from our usual pharmaceutical suppliers.
Okay,
who would the usual suppliers be for the outside GP market?
Well, what my understanding is that usually the GPs don't carry it. Usually they will get it from the acute hospital.
Yes.
They do recognize your prescription, no issue.
Oh, okay. So we can issue a private prescription.
Yes, correct.
So Hui-Ling asked a question also very practical. Is there some kind of service related to rental of syringe driver that Chung Seng, are you aware of?
No, they are aware of. Yeah.
So I think that logistics issue remain a barrier to providing pain management in the community.
Yes.
Drugs and access to syringe driver.
Yes.
Thanks, Chung Seng. Yeah.
Yeah, I was thinking that in a bigger picture, it's a close collaboration with the players that is already in the community, which means that like for example, Home Nursing Foundation is very big organizations whereby they really look at covering the whole of Singapore, and when the patient is approaching really end of life. I'm not sure whether the transition of care itself can be similar to a provider that is able to support this so-called things like, for example, symptoms control at end of life if they becomes very symptomatic. But of course, there are some that is very easily managed. Then they might not need to refer to the home hospices. Yeah.
Chung Seng, I'd like to ask one more question.
Yes.
In your experience working with frail elders, maybe advanced dementia, perhaps with pneumonia or UTI, delirium, end stage, and then they pass away, how often do you need syringe driver and morphine?
It really depends on the late so-called the trigger of the prior to death per se. If they have a MI, it can be very fast, whereby totally asymptomatic. But what I see in the acute hospital, it could be my view might be a bit skewed because in the acute hospital they tend to come in with things like, for example, a acute infection, which is not responding. Some of them are so-called fairly comfortable, and we can run away with just a fentanyl patch, and then we break through injections. But there are some that is very symptomatic. Yeah. And we have to run a infusion round the clock. Yeah.
Thanks, Chung Seng. Are there other questions? Can I just ask one last question to Chung Seng? Yes.
Yes.
In caring for frail seniors, say maybe advanced dementia with or without NG tube. You know, NG tube, of course, we can still serve morphine sometimes and suppository. Yeah, what kind of symptoms generally do you see? Maybe imagine a person that we see commonly in a nursing home or at home, you know, receiving regular nasogastric tube insertion from Home Nursing Foundation with or without indwelling catheter. So they are dying, perhaps, maybe there's a fever, and then we serve paracetamol through the tube. And then the breathlessness, we are giving augmentin, try to treat the underlying cause, but we think that this person may not make it, you know. So what kind of symptoms do you think are common in cases like this?
Okay. As rightly pointed out, there are two things. There's breathlessness, pain, and delirium in this group of patients. So these are common symptoms, and this is being covered. So if the patient is having an NG, the good way to go about it is that if the patient is having a chest infection, sometimes they do have a breathlessness. So while treating the patients with augmentin, we can give a little bit of morphine as well at the same time. But if of course treatment is successful, the morphine can be the patient is less breathless. The morphine can be taken off. But if the patient is not responding to the treatment, whereby the patient is getting more and more breathless, then what we can do is that we just increase the dose of the morphine accordingly. Yeah. For delirium, usually we will tend to treat hyperactive state rather than a hypo state. Yeah.
Okay, thanks, Chung Seng. Maybe there are two last questions from the chat. One is from Dr. Hannah. She asked a very practical question about the prescription writing. So in the hard copy writing, fentanyl patch 12, spelled out, bracket 12, MCG, Q72 hours. Is it enough?
It's all has to be capital lettered. So please supply fentanyl patch 12. MCG is you have to spell out the micrograms over 72 hours. So it's not Q72, it's over 72. 72 also have to write out in words. Yeah. Times how many patches. Yeah. All these has to be spelled in words, and then there's also the so-called chart. Behind the chart, you can put a chart. Behind the so-called how many patches you can, after you write down the patches, you can also give out the numbers of the patches as well. Yeah. Okay.
Okay, thanks, Chung Seng. The last question is from Dr. Tiffany. Tiffany 1, she says, is it possible to refer patients to Project Care or Project Dignity for patients who fit the criteria from the community?
Project Care, unfortunately, is under Dr. Seng though, and it's actually only relevant to nursing homes that is covered by. It's not all nursing homes is under Project Care. Some of the nursing homes that is under Dr. Seng catchment area. I think recently I just attended a talk by them. There's 30 over, but unfortunately maybe about 7 to 10 nursing homes are under the Project Care type. Yeah. So they have to be under Project. The nursing homes has to be under Project Care before they can go in. Yeah. So you are covered at nursing homes. If they're under Project Care, yes, you can refer to them. If the patient is really having this type of life-limiting disease. Project Dignity itself, which is advanced dementia, again, this one is you have to know where is the so-called the catchment zone of Dr. Seng before you can make the referral. Yeah. So basically, it's easier to go by the Dover Park catchment zone. It's the same. Yeah.
So thanks, Chung Seng. So what it sounds to us is that there is still a huge gap in supporting the majority of people who pass away at home due to advanced dementia, advanced frailty, and we are still hoping for some kind of decisive systemic resourcing to support all of us in the community, Home Nursing Foundation not included, but also many of our community GPs and providers who are keen to support people like them. Corinne, I understand she works with Project Care. She actually helped to answer Dr. Tiffany's question. Some of the nursing homes that they cover. Okay, so with that, perhaps we can close this afternoon session. So thanks, Corinne, for listing the nursing homes that's covered by Project Care. So with that, maybe there's a feedback form. If Jing Hui could cut and paste the link. Oh yeah, people can also use the QR code. So please help us to improve this session by giving us your feedback. So this is the first session, Dr. Lee Chung Seng. Next month, and for the next few months, we have a series of eminent speakers from Tan Tock Seng Palliative Care Division to share with us on the specifics in caring for people with respiratory symptoms, with renal failure, with cardiac failure, and finally, some of the very important communication and ethical dilemmas. How do we deal with them? So please sign up for all these webinars, and we hope to answer very practical questions that you have, so that all of us, doctors, nurses, we can support. I mean, the aging population is really imminent, and I think no hospitals is enough to take care of all our aging uncles and aunties, including ourselves in our future. So we need to contribute to this, and we hope that this could be a beginning of awareness and coming together to do this. So please give us your feedback so that we can improve on our CMEs. Okay, and Dr. Chan, okay, actually, there's once I signed up a patient with Alzheimer's disease. It was accepted by the coroner, but dementia is not a disease diagnosis. So dementia is a kind of you can consider as a kind of a cognitive failure, but the cause of it, Alzheimer's disease, I did it and it was accepted by the coroner. So, but frailty is really difficult to be a cause of death. Yeah, maybe Christina, you have any last words for us?
No, except to thank everyone and hope to see you again at our subsequent CMEs. Thank you so much, Dr. Lee, and for all of you who have participated and asked very good questions.
Yeah. Okay, so with that, we can close the session and give us your feedback. Okay, thank you very much.
Thank you so much. Take care. Yeah. Bye-bye.
Thank you very much. Thank you.
Hey, thanks, Chung Seng. Thank you so much.
Thank you, Wai Chong. Thank you, Christina.
Yeah.